Okay, I think we'll get started. Good morning, good afternoon, good evening to everybody. Thank you for joining us today for the Path Life Forum, recognizing World Pneumonia Day and the important role of medical oxygen in reducing morbidity and mortality from pneumonia, COVID-19, and other health conditions. Today's conversation is called Making the Case for Oxygen, Ensuring Continued Investment in Medical Oxygen Systems. My name is Lisa Smith. I'm Path Market Dynamics Medical Device Portfolio Lead and Project Director for the Strengthening Oxygen Utilization and Respiratory Care Ecosystem, or SOURCE project, and I'll be moderating today's conversation. We'll start by going over a few logistics just to orient everybody. I'm excited to announce that today's conversation features live French interpretation. To access translations, navigate to the bottom of your Zoom window and then click on the globe icon that says interpretation. You can then, you'll then see the option to listen in French or in English, and then you'll hear the translator speaking with the original audio behind them at around 20% volume. One of your speakers today will be providing remarks in French. So for English speakers, please navigate to the English channel to hear the English translation. If any of our attendees are unable to access the interpretation feature on Zoom, I will also do my best to provide a brief summary of the French remarks after each segment of the conversation. Further, we want to hear from you during this conversation, so please share your questions and comments with us by submitting them in the chat or the Q&A box at any time throughout the presentation. I'll be monitoring your questions and we'll be saving time at the end of the hour for them. In fact, I'd love to ask you all a question right now to kick things off. In your experience, what's one critical barrier to oxygen access? And you can type your answer in the chat box and send to everyone. We'll take a look at those. And for a final note on logistics, this call is being recorded and will be distributed for those unable to attend. So just a flag on that. Today's discussion will start with one person's experience struggling to access oxygen and its impact on family, followed by a panel discussion to solve oxygen-related access challenges with key thought leaders representing a variety of perspectives, clinical, biomedical engineering, government, and multilateral organizations. Now, to share a little bit about PATH, for those of you who may be less familiar with us, we're driving public health innovations that meet the most pressing needs of families, communities, and countries. Our work in pneumonia spans more than a decade, covering vaccines, drugs, diagnostics, and treatment delivery. Supporting oxygen access has been a significant part of these. And that brings me to why we're focused on oxygen today and why we must take advantage of the moment that we're currently in. Medical oxygen isn't just a life-saving treatment for pneumonia. Oxygen therapy is essential to ending preventable deaths stemming from respiratory conditions, obstetric emergencies, and non-communicable diseases among newborns, children, and adults globally. Yet despite this need, we've seen reliable access to oxygen remain inadequate across many countries, even during, or particularly during, the COVID-19 pandemic. Limited data, perceptions about cost, poor understanding of the impact on health outcomes, and the complexity of integration and maintenance across the health system all contribute to poor oxygen prioritization. In the last few years, countries have made great strides in improving access to oxygen by increasing procurement and distribution of oxygen equipment, investing in supporting infrastructure to deliver oxygen directly to patients, and by establishing systems and processes to effectively manage available supply. We must maintain and build on this momentum to realize not only sustainable oxygen access, but also equitable access across the globe. With that agenda in mind, allow me to introduce our speakers, each of whom provide an essential perspective on the ecosystem of respiratory care. We have Varun Raniar, is a biomedical engineer from Nepal, who will share his personal story with accessing sufficient oxygen therapy for his brother during our fireside chat, which we'll kick off with in a moment. Rafael Kayambanzakanja is a market dynamics officer with PATH in Malawi. A previous nurse in charge, he's now part of PATH's team working on oxygen and supports government partners in building long-term oxygen systems in Malawi. We have Biran Mboji is the head of neonatal health and IMCI office in the Department of Maternal and Child Health with the Senegal Ministry of Health and Social Action. He plays a vital role in working with country partners to integrate oxygen and pulse oximetry into national policies and guidelines. We have Engineer Millicent Alu, is the Secretary General at the Association of Medical Engineering of Kenya. She is a biomedical engineer at PM Shah Hospital in Nairobi, Kenya, with over 10 years of experience in the field. She has supported the function and maintenance of medical equipment, including those medical oxygen, across numerous hospitals. And we have Mohammed Emil, who's the technical officer in assistive technologies for WHO's Southeast Asia Regional Office. He's supported various implementers and multilateral organizations in increasing access to oxygen, particularly focused on access to appropriate medical equipment. Thank you, everybody, for being with us all today. We'll start with our fireside chat first. So Barun, thank you for joining us today to share your story. Do you want to introduce yourself to the audience and describe a bit about your background and your profession to start?
Thank you, Lisa. I am Barun Kumar Romyat. Namaste, everyone. I am a biomedical engineer from Nepal. And in 2020, I have supported the maintenance project with the headquarters in Geneva. And since September 2021, I have been working as a consultant biomedical engineer with WHO South Asia Regional Office. And I have also been one of the collaborative members of the region of International Federation for Medical and Biological since 2020. Prior to that, I have worked as one of the senior paramedical engineers for a nationwide medical management and maintenance project in Nepal, supported by German DFW since 2011. Now, I would like to share my experience. When my brother was a COVID-19 patient in 2021 at my Nepal, and I hope it will help somehow to understand the nature of excess from one person.
Thanks, Barun. And if you, in your next responses, if you could speak a little bit closer to the microphone, it's a little bit difficult or choppy to hear you. I just want to make sure everybody captures the important message that you have to share. So as a first question, could you describe the COVID-19 situation when your brother first became ill and the process of finding him a hospital bed with oxygen?
On 1st May in 2021, my elder brother Arun started to have breathing issues because of COVID-19 pneumonia. And the next day, he felt like he needed to get admitted to a hospital with oxygen facility. Our whole family and friends were frightened and trying their best to find a bed with oxygen supply in all possible health facilities. The 2 hospitals confirmed they had a bed, but when we got there, even after waiting 1 hour at the corridor, no one came for us. So we returned. When evening came and my brother's condition was so worse, we put him in ambulance and we were roaming door to door to different hospitals. 5 large hospitals refused to admit while his condition was getting worse. In one of the hospital, one nurse came inside the ambulance and just by seeing the oxygen flow rate of 10 liters per minute, she refused to admit my brother by saying that there is no bed available in ICU and it is impossible to save him now without ventilator. We all were losing hope. We all were crying inside, but trying our best to hide our real feelings of worry and fear, to not discourage each other, especially me, as I was physically there with my brother, who was also slowly losing hope. And I was trying my best to hide the real extreme pain and was pretending as if there is nothing to be worried about, so that my brother did not have panic. That was the situation when we all were praying and trying desperately to identify a solution. And luckily, we knew someone at the Ministry of Health who was able to help us find a bed in Bir Hospital, which is one of the largest government hospitals of Nepal. My brother was admitted in the general ward with oxygen supply because an ICU bed was not available.
Thanks. And once your brother had a bed, what did you discover with his oxygen equipment, and how did you go about addressing that?
After his admission, I found the oxygen regulator and flow meter attached to my brother's bedside was weak, and the one available nurse in the newly set up COVID-19 ward of 30 bed capacity was not able to fix the regulator. The nurse tried her best to reach maintenance staff, but she did not get any response, which might be because it was late at night around 11. She felt helpless in the situation. I had no option except trying myself to fix it. However, it was a huge challenge for me to step in because a minor mistake or failing to fix it would have been very serious consequences, as there were no other devices available except that. Luckily, I succeeded to fix at least the leakage by adjusting the knob and bolts carefully with my bare hands and without any tools. Still, it was not fully functional as the knob was broken. I was so worried and kept my eyes on it continuously the entire night and until the next afternoon when it had been replaced, as I felt like it could fail at any time.
Yeah, this is a really important point. Often people will believe, we have availability because there's a cylinder in the room, but the cylinder might be leaking or someone might not be trained to turn the cylinder on and effectively administer the oxygen. And so this is a really important point to make. What else did you do to help ensure your brother was getting the care that he needed?
I stayed there in the COVID-19 ward to take care of my brother. I was checking oxygen concentration and adjusting the flow rate accordingly, adding water in the humidifier bottle time to time myself. There was around 3 out-of-order humidifier bottles and regulators in the ward which were not replaced until I left the hospital. We followed the isolation protocol, meaning no other family members, including my parents or friends, came onto the ward to see us during that period. I was also helping the nurse by monitoring the blood pressure, pulse rate, oxygen saturation, and temperature of other COVID-19 patients in the ward, with only sanitizer and mask as available preventive, as there was limited hospital staff. Each patient had their own relatives to take care of them. And hospital had very limited resources, including biomedical engineers, technicians, nurses, and doctors. Patients had to manage the pulse oximeter on their own if they can. Patients had to wait for their turn to get nurse and doctors to see. 2 or 3 nurses made their rounds to each patient around 3 times a day, and 2 doctors once or twice a day. Doctors and nurses were often not available, even on emergency calls, and no staff was available from around 10 p.m. to 6 a.m.
So it sounds like you were playing a really essential role in the integrated care for your brother, and that he was very lucky to have you there. How long was your brother in the hospital, and how did you feel after your brother recovered?
My brother was discharged from the hospital on 11th May after 10 days because he was able to breathe without oxygen support, and there were many other COVID-19 patients waiting for a bed and oxygen. In fact, it was very challenging situation. People were dying because of lack of care, lack of food, medicines, and medical equipment like oxygen concentrators, ventilators, and oxygen supply. Beside these life-saving sources, there were also a scarcity of SpO2 devices, high flow nasal cannula, oxygen inhalers, portable X-ray machines, and oxygen filling stations, etc. Patients are trying to secure and reserve resources like ICU beds and oxygen in advance if they have good contacts, power, and hence the more needy patients who don't have contacts are dying because of lack of hospital beds and oxygen. But in this moment, I felt proud of my profession the most at the moment when I realized like I have saved my brother's life with my course as well as practical skills, knowledge, and experience.
Yeah, I think you made another really important point there, that to effectively deliver respiratory care, we're talking not about one technology solution, but often a combination of technology solutions from various different oxygen sources, so that you're planning for redundancy in the supply that's available, and also you have to think about how can you effectively diagnose patients, how can you effectively monitor them with pulse oximetry, ventilators, the masks, the tubing, the piping. There are lots of complex elements to kind of planning the logistics and effective delivery and supply of respiratory care. And I think that your personal experience really highlights that, and what an important impact and contribution that you've made in one person's life, but also I think in helping us as a community better understand all of these various and important elements of delivering care. Thank you so much for sharing your compelling story, Varun. It is just a great impact of the enormous impact that, or it's a great example of the enormous impact that access to medical oxygen has for so many lives. One story that translates to millions, really. And it so nicely lays out those key barriers. So to dive into these barriers even further, let's open up to our panel discussion with our other speakers as well. So everybody can come on video now. And we'll start with Raf, a colleague here. And Raf, can you describe a little bit more from the clinical perspective, what makes oxygen so complex to administer, particularly considering the unique needs of patients? And do you have examples of this that relate to pneumonia?
Yeah, thanks, Lisa. I think the first thing I often communicate about this is that oxygen is unique in the context that it doesn't have an alternative treatment to it. So if a patient requires oxygen, that's what they need to get. It's different from other clinical states like an infection or pain where we have different medications. And when you go to clinical practice, different patients will require different flows of oxygen, even different delivery modalities. This may be even in patients with pneumonia. So a child with two children with pneumonia will not require the same treatment. So you may put another child on 2 liters of oxygen per minute, and they will do fairly well, while another child will require 4 liters per minute. So it's not exactly standardized that a patient with this profile will require this many liters, and that during their stay in hospital will consume this much oxygen. It's not that standardized. So for health facilities or clinicians, a lot of it is trying to reassess the patient regularly, setting standards and targets that, okay, what oxygen saturation level do we want this patient to get? And it's not always clear in clinical practice because they don't always have all these pulse oximeters like you mentioned. They may not always have more options, like, the patient is on nasoprongs, they're not doing well, they need more liters, we need to change them, upgrade them to a face mask or a face mask with a reservoir bag. They're not always that options available. So that makes that treatment complex in the clinical practice. I think I can share that in summary for now, Lisa. Thank you.
Yeah, that's great. So what I heard you saying is, there is really no product substitute for oxygen. It is kind of an essential commodity that you need to have everywhere. That flow rate variability is an important consideration, and it's not standard. It's going to vary both within the course of treatment and for any given patient or across patients. And that regular reassessment and the dynamic nature of oxygen administration makes it particularly challenging and something for which there needs to be kind of constant attention given. That's really helpful, Raf. How can health facilities be best prepared to manage oxygen supply and estimate the needs of its patients given these unique considerations?
Yeah, thanks for that, Lisa. So I think the first thing is for health facilities to use the information that patients are giving them. So often there's not that detailed recording of oxygen consumption among patients or the different oxygen needs in health facilities. I can share a little bit more detail from a study that we did in Malawi a couple of years ago, where we found that close to 90% of hypoxemic adult patients were not receiving oxygen. So that's a detail that shows you that for this particular health facility, their oxygen need in general was more than the consumption at that particular point in time. While if all patients had been assessed and all patients were receiving oxygen, their consumption could have been much higher. And for planning purposes, they could have planned for a much more increased supply for oxygen. They could have ordered more oxygen cylinders, they could have had more concentrators, or even planned for a bigger PSA plant for whatever reason that they could have had. So oxygen and routine use of oxygen needs to be prioritized for terms of data recording, improving the patient records, make sure that you are documenting how much oxygen patients are receiving, and be able to review regularly how much oxygen we are consuming, so that by the end of the day, you could be able to do an analysis of your oxygen demand, oxygen consumption for different patient characteristics to help plan for health systems better. Thanks, Lisa.
Yeah, that's great. Having that firsthand account and good research that evidences consumption often outstrips what available supply is. And then further kind of improving information availability, having better data transparency to inform real-time demand of oxygen and respiratory care. I think those are really important facets to consider. I might do one more question, since I think we might be running on time here, but what are some of the challenges to ensuring healthcare workers have the appropriate training and capacity to appropriately administer oxygen to patients?
Okay, thanks, Lisa. I think the key challenge that I see, and again, from experience having to train a lot of health workers, is that when you don't have enough resources as it is to use in clinical setting for your patients to get accurate or enough oxygen, you don't have enough resources to spare to train health workers accurately on. So practical trainings is very important for oxygen devices or respiratory care equipment for health workers to know how to use them, for them to get comfortable to use them. So our trainings, when we are training health workers either on the job or undergraduate training, it needs to have that practical component so that they get comfortable with using the oxygen devices that they get to use. And when we go to undergraduate trainings, academic institutions, if we can support their skills labs, make sure they're equipped with all these equipment so that when they qualify, they don't just meet a concentrator on the bedside. They have already been able to practice this when they were doing the undergraduate training. And the regular trainings, whenever new information comes to light, we always go back to health workers to share this information. It needs to be there and be part of the system that is continuously learning and continuously developing the human capacity. I think the last point I can make is that we need to embed our biomedical engineers into the system because they understand the equipment. So a little bit of technical knowledge to the health workers can also help in preventive maintenance for the devices. I know Mel said we'll talk about more on biomedical engineering. I just wanted to make sure that there is that synergy between the clinical part and also the biomedical engineering part. Thanks, Lisa.
Yeah, that's great. So another set of important points there, practicing, having opportunities to engage with the equipment, both during education and thereafter as part of your continuing education, and then an integration, which we'll get into more, as you said, with biomedical engineering. Thank you, Raf. We're going to transition to the next speaker to ask questions from a different perspective. Thank you. But thank you for helping us better understand the clinical perspective. Now we're going to transition to Dr. Biran for a perspective on the government perspective of this. So Senegal developed an oxygen scale-up strategy as early as 2013. From this experience, can you identify any key learnings that other countries should consider to ensure the right guidelines are in place and that the policies are aligned for long-term oxygen access?
Alors, merci Lisa. Effectivement, le Sénégal a compris que l'oxygène médical est primordial dans l'offre de soins pour les populations. Alors, on sait que l'oxygène a permis de sauver énormément de vies avant et pendant la pandémie à COVID-19. Beaucoup d'hôpitaux au Sénégal sont équipés de centrales d'oxygène et l'utilisation de l'oxygène est quand même assez courante. Lors de la pandémie, on a vu que le besoin a vraiment augmenté et nous avons senti la nécessité d'élargir l'accès à l'oxygène au niveau des centres de santé et des postes, en plus des hôpitaux. Et le projet SPRINT, Scaling Pneumonia Response Innovations, a démontré qu'un bon usage de l'oxygène était possible au niveau des centres périphériques, c'est-à-dire des postes de santé, des centres de santé, et que ça pouvait aider à sauver beaucoup de vies. Donc, beaucoup de patients qui avaient des détresses respiratoires ont pu être sauvés grâce à l'oxygène qui était disponible au niveau de ces sites périphériques, parce que c'était une étude pilote. Aujourd'hui, plus que jamais, nous sommes conscients au ministère de la Santé de la nécessité d'élargir l'offre de soins en oxygène au niveau à tous les niveaux de notre pyramide sanitaire. Donc, maintenant, dans cette optique-là, le pays a acquis d'autres centrales d'oxygène à l'aide de partenaires, des bouteilles d'oxygène, des extracteurs d'oxygène. Et les défis actuels que nous avons, en tout cas, c'est de faire en sorte que cet accès à l'oxygène-là soit pérenne. Et pour cela, on a Alors, les enseignements que nous pourrions tirer de tout cela, c'est que l'oxygène, c'est très important. C'est un des médicaments essentiels qu'on utilise et qui sauve des vies. Il faut qu'on le rende disponible partout où le besoin se fait sentir. Alors, il faut qu'on continue l'acquisition des centrales pour que tout le pays soit maillé, qu'on ait de l'oxygène disponible partout. Et il faut également penser à la formation des prestataires, surtout sur l'utilisation de l'oxymétrie. On est en train de faire cela avec le projet TIMSI, sur l'utilisation du matériel d'oxygénothérapie, mais surtout sur les normes de sécurité. Et le plus important, c'est bien d'acquérir tous ces matériels-là, mais le plus important, je pense que c'est l'entretien de ce matériel, c'est la maintenance de ces équipements-là. Et on l'a compris et on est en train de travailler dans ce sens. Merci.
That's very helpful. What I heard you reflecting here was that there's, access is a medical oxygen is essential. Again, this kind of, I think, thread of what Rafa mentioned, and now we're hearing again, it's an essential medicine that needs to be available everywhere, and central planned production will help increase equitable access, and that's another component. And that while COVID-19 really, I think, made a lot of us aware of the demand and peaks in demand for oxygen, that there's a lot more that we need to do to improve equitable access here on out. And training and security norms and helping people understand how to safely administer oxygen, another very important component. And then finally, maintenance and management of equipment, which I think is another area where Senegal is doing quite a bit of its own volition and really, I think, providing a pathway and a direction for others to follow. So transitioning to another question, access to pulse oximetry is also vital to sufficient oxygen delivery. What is Senegal doing to ensure that pulse oximetry is accessible at different levels of the health system as a complement to oxygen delivery?
S'il vous plaît, est-ce que vous pouvez reprendre la question?
So access to pulse oximetry is also vital to sufficient oxygen delivery. What is Senegal doing to ensure that pulse oximetry is accessible at different levels of the health system as a complement to oxygen delivery?
Alors, pour cela, nous avons déjà intégré l'oxymétrie de pouls dans les directives nationales de prise en charge des enfants de moins de 5 ans. On a intégré cette directive-là en demandant aux prestataires les conditions, les situations dans lesquelles on leur a montré comment il faut faire l'oxymétrie de pouls, quels sont les enfants chez lesquels il faut faire l'oxymétrie de pouls et quelles sont les normes, c'est-à-dire les seuils. Et au Sénégal, les seuils que nous avons identifiés, c'est que si un enfant de moins de 5 ans a une saturation entre 92 et 94%, on considère qu'il est en hypoxie modérée. Et si la saturation est inférieure à 92%, on considère qu'il est en hypoxie sévère. Maintenant, si la saturation est à 95% et plus, il n'est pas en hypoxie. Voilà les normes qu'on a établies, qu'on a mis dans les directives, adressées à tous les prestataires de services, à tous les niveaux de la pyramide sanitaire, depuis le poste de santé jusqu'à l'hôpital. Maintenant, les enfants qui ont une hypoxie vont recevoir de l'oxygène. Ce qu'on est en train de faire avec le projet TIMSI, c'est qu'on a doté les sites pilotes, donc c'est 60 sites en oxymétrie de pouls. Il y a d'autres partenaires qui nous aident aussi à rendre disponible cet oxymètre de pouls dans d'autres structures. Mais ce qu'on est en train de faire, c'est de travailler en sorte que toutes les structures de santé du pays disposent d'un oxymètre de pouls. Et même au-delà, de le rendre disponible jusqu'au niveau des communautés pour que les gens puissent à temps voir le besoin d'oxygène et pouvoir adresser le patient là où il peut recevoir de l'oxygène.
Yeah, thank you. I think a lot of what I heard there is that there's all various different ways to perform integration. It sounds like the government in Senegal has put a lot of thought into the integration of pulse oximetry at various levels. They've defined the use cases effectively, set standard thresholds for what determines a hypoxic patient. They've broadly disseminated those guidelines at all levels of care, and then worked on piloting and expanding access to pulse oximetry at all levels of the health system, all different facility types, so that you can effectively diagnose and then triage or refer patients to then get the oxygen treatment or respiratory therapy that is needed. That's very helpful, I think, guidance for us to think about how we translate clinical insights and perspectives into broader normative guidance that the public sector might be setting. With that, I'd like to transition to Millicent to get a biomedical engineering perspective on some of this. Millicent, the first question I'd love to ask you is, what are some of the major challenges with maintaining the various oxygen production technologies available?
Thank you, Lisa. First, allow me to apologize. My camera has just decided to, it's one of those days, but at least I'm here. And yeah, so we have quite a number of challenges on oxygen maintenance that I want to believe that a number of us are probably familiar with, or maybe have gone through the same. And some of them, I would say, have been already mentioned by some of my panelist colleagues who have gone through the same experience as you have had. Barun said the same. So looking at COVID-19, which was a very great lesson to us, we learned quite a bit on oxygen when COVID-19 happened. And some of the challenges that we experienced and we continue experiencing, especially in LMIC, are, I would categorize them in different categories. Like if I start with the human resource, I would say that this quite a shortage of biomedical engineering, I would say globally, and more so in the LMIC areas where biomedical engineering as a profession hasn't been really recognized to be like one of the essential professions that are supposed to be in the healthcare facility. And so you find that we set up a very nice ICU, a very nice theater, very nice everything with all the doctors, nurses, and all the professions, but the biomedical engineer is not there. So simply because probably it's not clear to the management that it is important to have a biomedical engineer in the facility. So insufficiency or shortage of biomedical engineer is one of the challenges that make us not to be able to maintain these oxygen production technologies in the right way. And so we also realize that out of the few that are available in the facility, they don't have sufficient knowledge on the oxygen production equipment maintenance. Because if we are talking about oxygen production equipment or technologies, we are referring to all the way from the plant, the most sophisticated equipment. We will be talking about the oxygen concentrators, as simple as it is, it produces oxygen. We are there talking about the cylinders which are being wheeled around in the wards, in the theaters and all over. And of course, we're also talking about liquid oxygen. So there's quite a range of technologies that biomedical engineers are supposed to be taking care of, and they're supposed to be fully aware of what is supposed to be maintained. But one of the challenges that we experience is that majority of biomedical engineers are not having sufficient knowledge on the proper maintenance and even usage of these particular technologies. And so it's very difficult to maintain what you don't understand. And this actually originates from the training institutions that we are having. That's also a very big challenge, because from the time the biomedical engineers are being trained, you realize that the trainings that they're being offered is not up to standard. And so we graduate the biomedical engineers that are not competent enough to be able to maintain the biomedical the oxygen production technologies. And so it becomes very difficult before this particular biomedical engineer gets enough experience to be able to maintain these sophisticated technologies. It's time. And if you're a hospital and you've hired this particular personnel, that chance and those 6 months or 1 year of this person trying to do trial and error just to get their vector around. And so that's a big challenge from the training institutions that we have that. So going and one of the areas again that probably I would want to mention on the human resources, the use of the wrong personnel. As I indicated earlier, most of the administrators or most of the hospital management or healthcare facilities management are not very conversant of what exactly is this biomedical engineer supposed to do in the hospital. And so any engineer can actually present themselves to the management or the administrator and say, look, I'm able to maintain this equipment. And there's a very big difference between the training that a biomedical engineer gets to the training that an electrical or mechanical engineer get. They're totally different trainings, because biomedical engineers are trained together with the nurses and the doctors and the rest of other clinicians. And so they understand what it takes to be in the medical field. Any other engineering training is equally good and very commendable, but they are not wired to think hospital or healthcare facility wise. And so it becomes very difficult if we are to maintain this particular production technologies if you're using the wrong personnel to have them maintained. Now, coming to the resources, there's a bit of concern on the resources, because we can budget for everything. We will be able to budget for the equipment to come in. We'll budget for any other thing. But when it comes to the budgetary allocation for the maintenance, 90% of institutions do not think of maintenance as something that needs to be budgeted for. And for those of us who are very conversant of the HIPPO model, like a very small bit of equipment is budgeted for, but the hugest part of the equipment is never budgeted for, which is the maintenance. And so without budgetary allocation for the maintenance, it becomes very difficult for the biomedical engineers to maintain, or even for the facilities themselves to be able to allocate funds when there is a need for this maintenance at the right time. And so there are also budgetary allocations that are required for probably the consumables, the spare parts, and even the trainings, this in-service training. At times, I've been in biomedical engineering for over 10 years, as Lisa mentioned, and I've been working fortunately in private hospitals, which is a bit organized. But when you go to public hospitals, it becomes very difficult even to get a spare part. So if the spare part is not available, then it means you will not be able to maintain this equipment. And so that is one of the challenges that is put in place. Yeah, and then we're looking at in-service trainings. I went to school maybe 10 years ago And here it is, I get an oxygen concentrator that I've never seen. And you throw me in the deep end that, look, now you are the biomedical engineer to come and maintain this particular oxygen concentrator, or maybe an oxygen plant for that matter. I'm completely clueless. I mean, I've forgotten. So there's that bit of insight, I mean, in-service training that needs to be done to the biomedical engineers, especially for the policymakers and even for the management that are probably listening to me. It's one core point that needs to be considered, that ask your biomedical engineer, when last did you go for training for these oxygen production technologies? Give them budget allocation to go for trainings, 1 day, 2 days, refresher courses, and they'll be able to offer good services to us in the hospitals. Maybe as I finalize and take it back to Lisa, there are also various operational issues that actually affect the maintenance of these particular equipments. Like all the equipments in the hospital, you will realize that they're included in the inventory. You go to theater, equipments are in the inventory, go to ICU, everything is there. But when it comes to these oxygen production units, like the plant is located somewhere in the backyard, or the oxygen tank or liquid oxygen is located somewhere in the nowhere that even the CEO, the administrator doesn't go. So these things are never included in the inventory. And so if they are not included in the list of the items that we have, then it means that even they're forgotten in the PPM or plant preventive maintenance schedule, that all other equipments are done. And so they miss the plant preventive maintenance schedule. Because they are forgotten, they're somewhere that nobody sees them. As long as it is producing oxygen, everything is okay, until that day that it breaks down, then we realize, oh, it was never done for plant preventive maintenance. And we also realize, even as we look at it, that on the same note, most of the facilities do not have the oversight on the oversight on the maintenance of this particular oxygen generating equipment. And so you have one biomed that is running around the entire facility. This one biomed is the person doing the inventory, doing probably the maintenance, overseeing him or herself, and doing literally everything with nobody to support. So I literally think that human resource together with the resources and operations combined together are the major challenges that we are having when it comes to maintenance of these medical production technologies. There are quite a number of challenges, Lisa, but allow me to stop at that point. Yeah.
That was great. That was a very rich discussion of the complexities, and just to kind of share back some of what I heard. A recurrent theme in all of your comments were human resource challenges, shortages, not having enough biomedical engineers, the very tasks that they're responsible for, training on both an initial and then recurrent basis as technology changes, as the equipment, as you interface with different types of equipment over time, and as brands, makes, models evolve, that becomes a really essential component of all of this. It also sounds like the range of technologies that you're confronting on a daily basis within oxygen and more broadly, oxygen plus, that creates additional complexity as well, that we're kind of asking for this impossible feat to be able to effectively manage all of this. And so you need both more people, more training, more resources. And that biomedical engineering is really unique from other engineering professions in that there's this integration, not only with a knowledge of the technology itself, but also with the clinical perspective, the doctors, the physicians, people who are actually administering and delivering the care, and knowing how that fits within the broader health system. One thing that I would like to ask a follow-up question on, and I think that you touched on, is the budgeting for operations over time, spare parts, consumables, and that this is a particular challenge. I'm wondering, from your perspective, what needs to happen to mainstream biomedical engineering in policy making, financing, and procurement decisions, so that we don't have equipment sitting one place and then expect a certain result in terms of maintenance, both preventative and corrective, when we're not effectively resourcing those people to do that work.
Thank you so much, Lisa. And you've really captured almost entirely everything that I've said. So it means the students are listening. We are all good students. For the mainstream of medical engineering, for me, what I can say in a nutshell from experience is total involvement, like total involvement of biomedical engineering from the beginning to the end. And what do I mean by this? Total involvement from the need analysis. By the time we sit down and say, now look, we need to get oxygen concentrators, involve the biomedical engineers and see what exact concentrators do we need in this particular facility. And even before we get to the exact concentrator, let the biomedical engineers be able to assist the clinicians on the need analysis on oxygen management. Because if they help in the need analysis of oxygen management, they'll be able to give a comprehensive overview of what exactly will be required. And so what I can categorically say is the full involvement of the BME, that is the biomedical engineers, in procurement, starting from the beginning, specification development, commissioning, training even of the clinicians, and everything. If they're involved from the beginning, I want to believe there are quite a number that we miss out as the administrators, that biomedical engineers are sitting with somewhere in the workshop or sitting with somewhere, and because they are not consulted, they sit and say, look, you are not consulted, so we'll actually be able not to offer what it is that we have. So proper and full involvement for BME is very important. And when we are doing the procurement of the equipment, it's also very important to find out where exactly or what exactly are we procuring. If I'm looking at, I know, I think Raphael is the one who was talking about the oxygen management, and you're talking about how are we supposed to know what exactly is required. And in this, the involvement of a medical engineer in this is very important, because they know exactly. We have several analytical tools that are able to help, given the opportunity. Given the opportunity and given the resources, there are several analytical tools that are able to monitor the oxygen consumption in the wards, in the various areas. And these are only information that you can only be given by the biomedical engineers, because they know I can actually submit an entire facility and say, I'll be able to know how much I'm using in theater, I'll be able to know how much I'm using in ICU, I'll be able to know how much I'm using in various areas by just majorly submitting. The normal submetering for power or for the electricity can also be used in oxygen, just like the way we can submeter the water. And it will be very easy, because at times, you heard Raphael said very clearly that getting the data of oxygen consumption in the water is pretty difficult, because at times clinicians, they're just so busy, like they don't have that time to start recording the nitty-gritties. We'll get the data, but trust me, it will not be 100%. So if we can get the data loggers, or we can just get the submeters for this, we'll be able to be home and dry and be able to see this particular facility is actually using this. So now, for the mainstream BME, the main thing is involve them fully in everything. Policy making. What are some of the policies that are required for the oxygen management? Biomedical engineer needs to tell us what exactly is required. What about budgeting? When I buy 10 concentrators, what and what do I need? Do I need filters for my oxygen plant? If I don't need, what is the power requirement? In the event the main power is not available, do I need to budget for the generator to support this particular equipment in the event there's no power? Is there any maintenance kit that I need to maintain in the facility in the event we are down on oxygen, or down on a plant, or down on a concentrator? So decision making and full involvement is the key to the mainstream biomedical engineering. And probably just going back, integrating the training institutions, so that the BMEs are trained and wired to know. I know this is being done, but it's not at that level that is really required. Just integrate the training institutions so that they can make the BMEs to be the required BMEs in the field, to advocate for the right change that is required.
Great.
Yes.
Thank you so much, Millicent. In the spirit of time, I'm going to keep us moving to our last panelist, Mohammed Emil. Our last, but certainly not least, you've made some very significant contributions to the space, and are now working with with WHO, multilateral organization. I would love if you could discuss a little bit, share 2 or 3 of the most important learnings captured in the most recent report that you with Cyril and partners developed on and your specific perspective on building sustainable oxygen systems beyond the pandemic, and yeah, how we can more effectively improve oxygen access.
Thanks, Lisa, for that question. So you are aware, perhaps I'll put the link in the chat about the study that you were referring to. Actually, it looked at oxygen production capacity, the procurement, clinical management, and the collaborations. And apart from looking at the best practices, it has ultimately come out with some recommendations which could be very useful, as you were alluding to. So the first recommendation the report makes is to develop and institutionalize an oxygen management plan, which at times is missing, which means we will need to have oxygen monitoring mechanisms, have an elastic oxygen supply chain, which a lot of our colleagues in the panel alluded to, and capacity strengthening plan as well, like training we discussed, and ultimately having an annual biomedical maintenance plan. The next recommendation it makes is establishing an integrated digital ecosystem for a comprehensive oxygen response, which means we need to look at a unified oxygen management platform, not a decentralized plan, a hospital-based plan, which conventionally has been done and have created disasters in many places. So we need to have a unified management platform, a digital ecosystem, and have a multi-stakeholder task force for management of unified platforms. So, which means it also doubles up as a resource allocation tool whenever it's required. So the report has actually about 9 or 10 recommendations, but I'll maybe restrict myself in the interest of time to just 3. So the third one is about establishing clear actions for immediate as well as more systematic oxygen responses. So defining the what oxygen response means in an immediate or in a systematic manner. How do you reduce dependence on a single source of oxygen and diversify on store and supply or generate and supply, and or bedside options to centralized options, and establishing immediate oxygen responses to overcome shortages in a case of an emergency. And finally, the countries with limited oxygen capacities, production capacities specifically, how do they collaborate with oxygen surplus capacities? So that's one of the other sub recommendations of recommendation 3. But I'll share the link in the chat, and colleagues interested can go through it in detail. Thank you so much.
Thank you. That's so great. So, I think reflecting back, developing and institutionalizing an oxygen management plan, establishing an integrated management, like a digital ecosystem platform for across all of the health facilities for oxygen management, which would then help with subsequent allocation of new equipment or resources, and then establishing a response mechanism for normal and emergency scenarios of oxygen utilization. Thank you. That was very helpful. Building, one final very quick question, building from your previous experience working at PATH and other places, what would you say is the key role of multilateral organizations like WHO in supporting sustainable oxygen systems?
I think one of the important points that I want to bring out here, and thanks for this question, this platform is perhaps one of the best brains on oxygen systems here. So the important message here is that the investment in oxygen which has been made during the pandemic needs to be sustained, so that it can be utilized for health system strengthening and for future pandemic response, which means that countries need to have strong operations and maintenance plans for such equipment, oxygen equipment, and this could be through an outsourced agency or by developing in-house capacities, although the latter option is more preferred. And in some cases, booster compressors for filling cylinders can be installed at certain PSA plants with a hub and spoke model for supplying oxygen cylinders to nearby smaller facilities. Because PSA plants are energy intensive, so the addition of green energy like solar power generation plants may be explored to reduce electricity costs. This will not only make the health facilities self-sufficient in terms of generating oxygen, but also in powering the oxygen production equipment. So evidence on cost effectiveness of this solution is yet to be established, but it's worth exploring, and I know a lot of organizations are exploring that as well. Thanks.
Great. Another really wonderful set of suggestions there. And I think what you opened with as a comment is really the premise for this entire session, which is, you know, investments that have been made during the pandemic are things that need to be sustained at this point. And so the tact, the strategy for engaging moving forward looks a little bit different, but we can't lose any of the momentum that we've established over the last number of years and the increased awareness, and that there's quite a bit more work to be done to finesse, to improve, and to make connections in reliable oxygen access. So thank you for that. I know we're running a little short on time now. So what I'd like to do is close our conversation with kind of final comments from the speakers, and do this with about 30 seconds per speaker, just so we can hear from everyone. And I'd love to start with Varun to get your voice back incorporated into this. And can each of you share, with the barriers that you previously noted in mind, and assuming that money was no object, financing was not an issue, what are your 3 oxygen access investment priorities? So Varun, we'll start with you.
Thank you, Lisa. There are many cases I know when SARI patient with respiratory syndrome brought to capital city Kathmandu, Nepal, by helicopter to get critical care and oxygen therapy. Almost all critical care, including oxygen therapy, are only available at central level or in major cities of urban areas, which is good for people residing in cities. But for poor people residing in rural areas and villages, need to pay very high cost to travel and accommodation to get these critical care services, including oxygen, which makes most expensive, least accessible, and available of critical care services for poor and most vulnerable people. So I would say strengthening critical care services, including oxygen in rural areas, and ensuring of availability of biomedical engineers and technicians to ensure the safe and proper functionality of medical equipment would be the most prior for now.
Great, thank you. Okay, over to Raf.
Thanks, Lisa. I think the first thing I would say is that we need to cover the current gaps. So make sure that the current production capacity is increased so that patients who need oxygen now actually get it. The second thing I would say, let's improve our health sector trainings, our academic institutions, so that there is more accurate training and update of information. The last thing I would say, let's nationalize and make oxygen indicators a national priority as well. Malawi is doing this, trying to make oxygen indicators into the national set of indicators. It may help for accurate and real-time tracking of oxygen consumption and demand in countries. Thank you.
Great. Dr. Baran?
Moi, ce que je veux dire, c'est que ceux qui ont déjà accès à l'oxygène continuent à l'avoir, qu'on fasse de sorte que ce soit pérenne, mais que ceux qui n'ont pas encore accès à cet oxygène-là puissent y accéder, surtout au niveau des zones périphériques. Mais le plus important, c'est que ce soit pérenne et qu'il y ait une bonne maintenance des équipements et du matériel. Merci.
Great, thank you very much. Millicent?
Thank you, Lisa. Maybe as I wind up, probably for me, it is the advocacy on the biomedical engineering involvement, which is very key, so that the biomedical engineers can be more involved in the oxygen management of the health facilities, and more so, maybe more of trainings for the ones that are already involved, more in-service trainings, many webinars like this that you've organized, as many as possible, like countless number of webinars, just to ensure that the biomedical engineers are updated and up to date with the current trends and even what is expected of them from different standards like WHO and many others. Thank you.
Great. And Emil.
Yeah, sure. Thanks. So the findings and the recommendations that we have been discussing may not be new, and there have been prior incremental moves to strengthen the oxygen ecosystem and make them more sustainable. But what the pandemic has provided is a new renewed prospect for solidarity, both within and between countries, and for a more coordinated oxygen response. It also reaffirms that a collaborative, people-centric and whole of the government approach to medical oxygen is needed for a health system that is able to respond to the future crisis. Thank you.
That's great. Wow, thank you. What a helpful set of recommendations. I think that there's a lot here that different donors, financiers, governments can be drawing from to inform, you know, what to do next. And some of what I heard, just to reflect back, is, you know, equitable access. This is a key theme we opened with, but maintaining, sustaining the gains that have been made and expanding to rural areas, to all populations, to fill the gaps. That will require additional equipment installation, which any of that new equipment, all of that new equipment that we've seen, what a blessing in the last number of years to have this influx of new equipment. But now we really have this task at hand to maintain, manage equipment effectively over time. This is where the role of biomedical engineers is so important. So doing more advocacy to mainstream their involvement, and to make sure that there's increased financing for trainings and education, continuing education for both the biomedical engineers as well as the clinicians, improved training curriculum and incorporating that throughout. And I think what Mohammed Emil said at the end there was really important, that we have this kind of collective increased awareness around the importance of respiratory care. And how can we build on that? How can we better coordinate across groups, across countries, and within countries? And how can we develop systems, platforms, sustainable strategies to be able to make sure that we connect the dots and have this reliable care and service provision? What a wonderful set of perspectives. I want to thank everybody for your participation, for your time, for your interest, for those of you that are listening in and providing questions in the chat. Yeah, this is an important issue that I think we at PATH and many others around the world have realized there's just so much more to be done. So I really look forward to kind of continuing on this journey with everybody, and making a difference, having a big impact in improving reliable access to respiratory care services. So keep on doing what you're doing, and thank you so much to everybody for your participation and your perspective.